Without further ado, I'd like to introduce our first session of the day, which is entitled Defining and Innovating Strategies. And we have the pleasure of kicking off today with a live viewing of the Canadian Breakpoint podcast, hosted by Dr. Rupeena Purewal. This podcast is designed to create awareness of increasing AMR and our fight against it, to focus on discussions around new diagnostic methods, how to implement technology in clinical and laboratory medicine, and review emerging infectious diseases. The title of this episode is Canadian Sepsis Strategies, Optimizing Patient Management with Antimicrobial Stewardship and Equity. Dr. Purewal is a pediatric infectious disease physician. She was born and raised in Edmonton, Alberta, and completed her medical school at the University of Pécs in Hungary. I did have to look up how to say that. It is not spelled that way. Thereafter, she moved to the United States for a 3-year pediatric residency program at West Virginia University. She returned to Canada in 2017 to start her pediatric infectious disease fellowship at the University of Manitoba. Dr. Purewal has been working in Saskatchewan since 2019 as a clinician and academic physician at the University of Saskatchewan. On today's episode, she will be hosting 2 members of the National Sepsis Action Plan, Dr. Barrett and Fatima Sheikh. Dr. Barrett has an MD from the Sheikh School of Medicine at the University of Western Ontario and completed her training in internal medicine and adult critical care medicine at the University of Toronto. She is presently the medical director of the Recover Home Ventilation Program at the Toronto Grace Health Centre and is an affiliate scientist with the Health Systems and Policy Research Collaborative Centre at the University Health Network. Her academic work focuses on evidence to inform policy development. She has real-world experience in this regard in Ontario and is presently in her 4th term as a member of the Ontario Health Technology Advisory Committee at Ontario Health, and she sits on several working groups with the Ontario Provincial Long-Term Ventilation Strategy. Fatima Sheikh is a Ph.D. candidate at McMaster University and a Canadian researcher focused on health equity and the social determinants of health. Her research focuses on understanding how social determinants of health influence both the incidence and outcomes of critical illnesses. She also explores how these determinants shape healthcare delivery with a goal of informing equitable health policies, responsible evidence use, and inclusive care practices. In addition to her academic work, Fatima holds a role in Equity, Diversity, and Inclusion and Human Rights Department at Hamilton Health Sciences. And in this role, she leads collaborative initiatives with communities, patients, and regional partners to design and implement processes for collecting sociodemographic data and advancing equity, inclusion, and anti-racism across the organization. So please welcome them to the stand.
All right. Welcome, everyone, to another episode of our podcast, The Canadian Breakpoint. Thank you so much for tuning in. It's my pleasure to be here today to actually come for the second time and do a live podcast. And for our listeners that are tuning in virtually, welcome as well. And thank you to our guest speakers today. So today we're going to be talking about a really important topic, and it's regarding sepsis. So before I begin, I wanted to get a poll from the audience to see kind of what we know about sepsis and those that have encountered someone with sepsis. So sorry, I don't have my ticker up here. I have to advance the slide. Okay, so I think some of you guys know how to enter into Slido. So you can either use the QR code there or through the app itself. And so the first question is, what is sepsis? Perfect. Looks like everybody pulled in and, so have. Okay, I think we'll close that poll. So I think majority of our listeners today realize that it is an organ damage produced by inappropriate inflammatory response to infection. So that's a correct answer. Next question. So which of the following of these is a sepsis warning sign? Okay, perfect. So yes, all of the above would be, thank you. All right, and then we'll talk to Dr. Barrett more about elaborating on some of those warning signs as well, but great job. Okay, and then our last question is, has someone, so either in this room or any of our online listeners, has anyone in your life, like a close friend or family member, gone through sepsis? And so our options here are yes or no, or I've never seen or heard about it before. Okay, the majority of our folks are going to know. All right, so now we're going to begin by talking about sepsis and really understanding the work that both Fatima and Dr. Barrett have done in this area. So without further ado, I think I want to start by asking both of you, how would you define sepsis, and in which clinical setting does this really occur in, and which healthcare professionals are really best positioned to manage this condition effectively? Yeah, so sepsis is sort of defined as the body's sort of out of control, over excessive inflammatory response to an infection. And it's interesting, some of the people who answered in the poll said that it was a blood infection, which is true in some ways. And so it's important to know that any infection really can cause sepsis. And it's often sort of thought of as either the bacteria or the virus is sort of eating away at the body, or that there's bacteria in the blood. And while there's sometimes bacteria in the blood, it doesn't always have to be that. It can be just a soft tissue infection. And it's really the immune response, the body's immune system gets so overwhelmed and so, not overwhelmed, sorry, almost overactive that the inflammation causes organ damage. And the main way that the organ damage happens is actually through shock. So people's blood pressure is low. And so that's why one of the question where it was, what are the warning signs and the sort of signs and symptoms of sepsis? They're typically signs and symptoms of an infection. So fever, cough, urinary tract symptoms, a wound infection, but then also not enough blood flow and oxygen delivered to the brain because the blood pressure is low. So dizziness, confusion, sort of not feeling foggy, decreased urine output because there's not enough blood flow to the kidneys. People develop sort of some people develop cold fingers, and then some people, they're red and they're hot, like your everything is red and sort of inflamed because you're of the inflammation. So it's not necessarily the infection, it's the body's response to the infection. And really, anyone in the health system could see someone with sepsis. And that's, I think, a very important point, that this isn't something that should be just only sort of the purview of people in acute care hospitals. We know that the majority of cases of sepsis actually originate in the community. And so any sort of first point of contact with the health system, that health provider needs to be aware of sepsis, know what it looks like, because they could be encountering it for the first time in that person's case. Okay. Yeah, so it sounds like from kind of the warning signs that you mentioned, that the public and others are healthcare providers should be aware of, are quite alarming, and can sometimes happen quick as well. So sounds like very devastating. And so is this a treatable condition, and within kind of our healthcare infrastructure, what types of resources do we really need to treat such a condition? So the first most important point is we need to be able to recognize it. So the clinicians looking at the patient need to be able to have the pattern recognition or the infrastructure within their system to have warnings or like red flags in their EMR to say this patient is developing shock, they're developing organ dysfunction, and they have an infection. This could be sepsis. And then the most important thing, and we know there's very clear evidence about this, that you need to give antibiotics as quickly as possible. And that's where I'm sure in this room it's like, but that's actually an evidence-based recommendation. if you can start to treat that infection early, you can then prevent some of that later inflammation and organ damage. So it's getting control of the infection as quickly as possible. Often, when individuals have shock associated with sepsis, they need to be treated at an acute care center, because they need volume resuscitation with intravenous fluids. And so you can't really, I don't think a family physician would be able to do that in their clinic or sort of community health centers. That's sort of beyond the scope of what could be done there. You need to be at a hospital where you can have blood work drawn, repeat blood work drawn, get IV fluids. You need to have appropriate investigations done to be able to find the source of the infection. And then also key, and I think important to this room, is appropriate cultures done so that we know what the infection is caused from, so that we can then narrow the antibiotics and make sure that we're not delivering too broad spectrum antibiotics. Right. Yeah. And that ties us back to antimicrobial resistance and building resistance if we're not doing that. So yeah, definitely going kind of broad empirically. Sounds like the approach, need a multidisciplinary team. Definitely need to be in a setting where there's enough resources to manage kind of acute changes. So yeah. And with that, I mean, there comes the burden on the healthcare system as well. And so what have you guys seen, or what are the effects or the economic burdens of this on our healthcare system?
Yeah, I think it's a really important point to highlight there. I think just even in the description that Callie provided in terms of the level of care required, we know that sepsis is going to be costly. And we even think about this from the number of Canadians that are impacted, or the number of individuals worldwide impacted. So we know in Ontario alone, we're looking at upwards of $1 billion associated, Yes, $1 billion in Ontario associated with treating sepsis. And remember, that's sort of the hospital associated costs. But we know the other piece to this is that once individuals have had a sepsis case, they are at risk of coming back into our hospital systems, increased risk of diabetes, cardiovascular disease, so on and so forth. And so all of the costs associated with treating those downstream sequelae. We did a study a few years back looking at the concept of high cost users. So the individuals that make up a small portion of the population, but a disproportionate amount of healthcare spending. And we know that sepsis is actually a risk factor for becoming a high cost user. And so really when we're thinking about this in terms of prevention of a sepsis case could potentially yield cost savings for the healthcare system. And this doesn't even begin to touch the pieces associated with the individual, their families, not being able to return to work, the psychosocial factors, associated caregiving costs, and all of the burdens associated with that. So we're really focused on some of those health system costs, but there are also significant costs associated with some of the downstream impacts of sepsis.
Yeah. And I think one of the things that I think maybe isn't necessarily recognized unless you've experienced sepsis yourself, a loved one has, or you've treated it, is the people who have really severe sepsis and have shock need to be admitted to an intensive care unit. Mm-hmm. And to treat that low blood pressure, we have to give medications to increase the blood pressure. And some of the complications associated from that medication is we actually squeeze the vessels to the point where the digits and the toes, you don't have enough circulation. So you hear about people requiring amputations when they have sepsis. And that's as a result of the blood flow being diminished blood flow to their fingers and their toes. And there are people that survive sepsis and have lost limbs. And the prolonged course of critical illness, we know that every day in bed, your muscles are just sort of atrophying, and the inflammation, the muscles atrophy. So then people have incredible weakness. They get nerve damage. So they're surviving an episode of sepsis, but now they've maybe lost a limb or two. They've got residual kidney dysfunction. They might need dialysis for the rest of their lives. They have foot drop. They have intractable nerve pain. They need months and months and months and months of rehab just to have the strength to be able to sort of ambulate and toilet themselves. Mm-hmm. So it's for people with severe sepsis, it is a catastrophic, life-altering event. And even those who have a milder case of sepsis, we spoke with someone yesterday or 2 days ago who had a mild to moderate case of sepsis, needed vasopressors, but
continues to have sequelae, is back at work, but is continuing to like in and out of visits with the physician because she's having recurrent infections and things. Her body has just been so messed up from 9 years of sepsis. So it's really, it is really life altering.
Yeah. And it sounds like from the population that affects, obviously, I mean, there's certain risk factors for certain conditions that we know of in medicine, but it can really affect you at any stage. So I know that there's cases with childbirth, there's cases, routine cases, like I work in pediatrics, so we see it all the time there as well. And you really can identify a lot of risk factors when somebody's going to have a severe presentation or a milder presentation. And so I know that we talked about key kind of prevention and education around that. And I know you guys have done a lot of work around the Sepsis National Action Plan. And so I wanted to kind of shift gears to that now, because as we know that this is a very devastating condition. It can, we need to make awareness. And so I want to kind of let our audience know. I know you guys presented it last year as well, the symposium. I think some of our listeners were there. And so kind of what have things, what really led you to do this work?
Yeah, I feel like it's worth taking a step back and going into sort of 2017 when the World Health Assembly put forward Resolution 70.7, which really, required member states to implement protocols, standards associated with, sepsis early detection, management, and so on and so forth. And I think that was really the impetus for a lot of this work, at least in 2017. Since then, we've done a lot of work sort of looking at existing policies outside of Canada to understand, why they were implemented, how they were implemented, so on and so forth. And in most cases, these are examples of reactive policies. So a tragedy occurs, it hits the news media, and there are subsequent efforts that are put in place. A good example of this is looking to our counterparts in the US, particularly in New York around Roy's regulations. These are an example of one of the first state-mandated sepsis policies that were implemented after the tragic death of a young child that could have potentially been prevented through early detection and appropriate management within the hospital setting. There are other parallel examples of this. I think we've done some work around foodborne pathogens where there have been subsequent policy efforts. And so we wanted to take a step back and think about what would, what would a coordinated plan look like for sepsis here in Canada. And so we started with a jurisdictional policy review of existing sepsis policies, guidelines, and health professional training standards in Canada. And this work is forthcoming and will hopefully be published soon, but just sort of a few tidbits from that review. We didn't identify a single sort of national policy or framework in Canada to guide what provinces and territories should potentially be implementing. And I think in the absence of that, we see a lack of policies and guidelines across most provinces and territories in Canada, and where it exists, they don't cover the breadth of populations at increased risk and limited integration of some of those international guidelines in that work. I think we talk a lot about early detection, and it's so critical. But I think in order to facilitate that, we really need to think about training for our health professional training standards and whether or not this is actually included as a competency. Are physicians, nurses, or allied health professionals trained to detect the signs and symptoms and escalate care accordingly? When we look at the physician training standards, in most cases, sepsis isn't considered. And where it is, we feel that it isn't considered, in a way that is appropriate for a medical emergency. And I think for nurses, for our paramedics, for our allied health professionals, I think Callie had mentioned, everyone in the health system sort of has a role to play in some of that early detection. We see a lack of consideration. And so I think that for us highlighted the opportunity to implement a sepsis national action plan that considers those important risk factors, that facilitates the implementation of sepsis as a core training competency to facilitate some of those downstream pieces that we were talking about.
Okay. And it sounds like other countries, as you mentioned, the US particularly have a sepsis national action plan. Are the components of that, like you touched on some of them, or the components, some of those similar components that you guys integrated into your action plan?
Yeah, absolutely. So other countries have implemented sepsis national action plans, and I'll give some of those examples. But I think when we're talking about that, the components really boil down to some of the prevention efforts. So thinking about vaccines and other things that can help prevent infections and then subsequent onset of sepsis. We're thinking about awareness. So I think, in this audience, we saw the polls earlier, and majority of you had said that no one in this room was impacted by sepsis. And we often hear that people learn about sepsis when a loved one has had it or a relative has had it. And we don't know, it's not common to know sort of the signs and symptoms in the same way that we know the signs and symptoms of, for example, stroke. So if someone is, having a stroke, whether it's your family member, whether it's someone on the street, even if you can't name off all of the signs and symptoms, you are able to identify that something is wrong. It's a medical emergency. I need to call 911 and get this person care. When they get to the hospital system, we have protocols and policies in place in order to escalate that care. So I think the prevention and awareness pieces are really important. And then when individuals get into the hospital system, standards in the emergency department, it's such a complex environment. We heard from a speaker yesterday about some of those complexities and some of the challenges, but an opportunity to protocolize some of that care so that early detection and management becomes routine. I talked a little bit about the training standards for everyone in the health system, so beyond the emergency department, what that looks like. And then I think there's opportunity for developing quality standards, quality improvement initiatives, and through all of this, integrating sort of those data pieces, our ability to understand who in Canada is actually impacted by sepsis, and whether the efforts that we're putting in place, whether those are policies, whether those are guidelines, whether that's inclusion in health professional training standards, having the intended impact. And so I think that's going to be a really, really important piece going forward. And I think the ability to report on those pieces so that we can evaluate our efforts continuously.
It sounds like definitely looking at some multidisciplinary or multifaceted kind of approach is really important. And you talked about prevention, diagnostics, education. I think those are all kind of the key points. And all of this, I would assume, requires a lot of money, funding. And so when we're looking at kind of things that are, burdening our healthcare system, such as conditions like sepsis, has there been measures by the Canadian healthcare system to help us implement such action plans to kind of fight or to create awareness in regards to conditions like sepsis? As our jurisdiction review identified, there isn't yet a national strategy or provincial strategies, really. And I'm not sure it would cost a ton of money to actually address this issue. A lot of the work involves just bringing together the people that are already doing work in these given areas and just ensuring that sepsis is a part of a training standard, ensuring that prioritized quality metrics for hospitals and healthcare centers, that sepsis is one of them. So this, I don't think this requires a new line item in any system's health budget. Right. It just requires a bit of a reorganization maybe, or a reprioritization of sepsis. Right. And I think in terms of, so what has the Canadian government done? I'll say that the AMR efforts apply to sepsis. Right. So every person who dies of AMR is likely dying of a sepsis-related death from a resistant pathogen. So sepsis is sort of like the human face of AMR. And the Canadian government funded the Sepsis Canada, the research network. So they gave several $1 million to scientists, which Fatima and I, some of this work was supported by Sepsis Canada. And so there's been a pool of money for research. A pool of money is now spent, so there's no further funding. But there hasn't been a sort of a policy effort. And so that's really some of the work that we're doing. It's very hard for a single government entity to lead this work. the federal government is not going to be able to solve this problem. A provincial government is not going to be able to solve this problem. And it requires having the key government stakeholders and the decision makers and then the clinicians and the patient partners. And so what we're hoping to do and what we're starting to bring those people together, and we're laying out the ground, sort of the plan of here's what we're going to do. We've mapped out what's missing. We've mapped out what exists, and then we're going to work on basically filling the holes in the policy gaps together, coordinated, so that we're not all reinventing the wheel in all the different provinces. Yeah, that's fair. And I think we talked about this at one of yesterday's talks in terms of the provincial healthcare differences that we have as well. So again, that probably poses some challenges when you're kind of coming from a national front, just with having different provincial healthcare systems. But it sounds like awareness is probably kind of a key factor in this as well, and why we're also here today to make people aware of this condition, what your guys' plan is, and that is a national plan. And we talked about some of the barriers that exist, but where do you think the key kind of awareness gaps are within, let's say, the public, within policymakers or healthcare professionals?
Maybe I can start with the public piece, because I think that is so critical. So there was some work done by some of our colleagues, also funded by Sepsis Canada. They tried to understand, how many Canadians know what sepsis is, how many Canadians know the signs and symptoms of sepsis and some of those preventative efforts. And across the board, the percentage is relatively low. I think what's important, though, is that awareness differs by region, by sex, by education, and by ethnicity. So I think there's a critical piece to all of this work, which is that ensuring our communication about sepsis and ensuring who has that sort of education is tailored to the populations that are at increased risk, which is often influenced by, the social determinants of health, where you live, what you have access to. And I think it's really challenging because sepsis is, a heterogeneous condition. Everything from, any infection can lead to sepsis. We've had patient partners talk to us about, a paper cut that led them to a sepsis incident. We've had individuals who've had pneumonia and come into hospital, and there's been some downstream effects. So it is a challenging condition in that sense, but I think there's lots of opportunities to think about what prevention strategies look like. And it really starts with, folks understanding what sepsis is and understanding some of those signs and symptoms.
Yeah. And so obviously we've talked about the components of the Sepsis National Action Plan. So what is kind of the future in this? So what future initiatives does your team have planned? I know it seems like we've definitely looked at the data. We know where some of the gaps and barriers exist. And so what does the future hold for us?
Yeah, so we're starting to pull together the group. And to support this work, we're applying for CIHR funding. If we don't get the funding, we're going to still start the work and then continue to try to find funding. The first step that we're going to do is we're going to do a sort of proper comparative health system evaluation of what have other jurisdictions done and what's worked, what hasn't worked, and actually get the leaders of all the different national action plans together, host a conference, and then we're going to try to figure out what can we learn from those different examples that are applicable to Canada. The next step is we're going to bring together the key stakeholders and decision makers and healthcare providers and sort of people who will be implementing and map out how we are going to fill the gaps in each area. And this is going to be very different. There's going to be, we need to address reporting. We only, Quay only reports nosocomial cases of sepsis. And I think this is one of the sort of academic decision makers, political sort of gaps, is that sepsis is always viewed as an acute care condition. And we consider, infection prevention and control in hospitals and hospital-acquired, surgical site infections and C. difficile. And those are very, very important. I'm not saying they're not important, but that's a minority of sepsis. 80% are coming from the community. So we're not measuring those, reporting those, tracking those. We don't know what the outcomes are for those people in sort of a comprehensive way. So reporting metrics, quality improvement metrics, making sure every hospital in the country within each province has a clear standard for how are they going to detect sepsis, how are they going to treat it, making sure all healthcare professionals know what sepsis is. making sure it's in hospital accreditation standards. So is every emergency department, OR, recovery room, medicine ward, surgical ward, all the different areas where sepsis could be developing and percolating in patients, is that part of an accreditation standard for the hospital? Right. And then research, making sure that we have good research. And then another little point of this is going to be public awareness. So we want people to know what sepsis is. And I mean, as a clinician, you know that so much of what we do is pattern recognition, right? And sometimes you can cognitively get down a pathway where you stop asking, what else could this be? What else could this be? What else could this be? Mm-hmm. And you know, if patients knew what it was and they said, man, what is sepsis? That's really powerful. Mm-hmm. You know, a family member of mine called, we get these phone calls, I have this problem, what do you think? And when she started to describe it, it didn't sound that bad. And then she said, I'm worried this might be sepsis. And it immediately made me think, oh, it actually could be. Mm-hmm. You should go to the hospital. And she ended up needing to be admitted and have an abscess drained. Oh. So, you know, it's that sort of empowering patients to be able to advocate for themselves, I think also would be very, very important in this. Right. And so public awareness and awareness within health systems and within decision makers is going to be key.
Yeah, and you bring up a lot of good points, like we talked about, and like stroke symptoms and signs are very, you know, we have advertisements and recognition. So I think your initiatives sound like creating some awareness around where the public can identify that, I think is definitely one of the key points. And it hasn't been done. I mean, for sure, I think if we were, I think everybody in this group probably understands that, but some of my listeners out there, they might be showing some of this information for the first time. So thank you so much. I do want to give you guys the opportunity to kind of give one key message. I mean, there's probably a lot of key messages out of today's talk, but I think one key message that you want our audience to kind of take home from today, to think about, to you know, speak up or integrate into their decision making.
Yeah, that's a tough question.
It is.
I would say that my one key message would be that, you know, sepsis is a medical emergency and that, you know, a coordinated and proactive national action plan could save lives. And I think there's a role to play for everyone in this room and for the listeners. I think we've highlighted some of those opportunities. And so we welcome that collaboration as we move forward in this work. I would say that I think we need to stop thinking about the barriers in our health system as reasons for why we can't address this problem. Right? We just make sure that people are working on the things that they have jurisdiction over. And so this is doable, and we just need to all come to the table and work on it.
Awesome. It's a great message. Well, thank you so much. I know I learned a lot about your guys' action plan in terms of sepsis in general. I think it brought about awareness to our group here, to our listeners internationally, maybe other centers or sites that have created such a plan would speak up and bring up kind of their efforts. So thank you so much for doing such important work. I think it's really important, like you mentioned, Dr. Barrett, to action. We just need action, and that's and we need to prevent such devastating conditions for sure. I think the work that you guys have done is fantastic, and we look forward to hearing about more of your work that continues in this area. And so I'm sure we'll have future episodes for that. So thank you so much for being guests on our podcast today. Thank you everyone for listening, and for our listeners that are tuning in virtually or they'll be able to find our podcast on Apple, Spotify, or Google. They, I'm sure, can reach out to us if there's any other comments or questions. And I want to thank all of the supporters and for the AMR Symposium for having us here today and be able to discuss such an important topic. Thanks so much.
Thank you.